For months, the episodes came without warning. A sudden hammer of pressure behind the eyes, a heart lurching into a sprint, sweat soaking through a shirt in seconds. And every time a clinician ran the standard tests, the numbers had already settled back to normal. The working explanation was anxiety. It was a reasonable guess. It was also wrong. To understand why that mistake was so easy to make, you have to understand what the body looks like when it is genuinely overwhelmed by stress. The adrenal glands, two small structures that sit on top of the kidneys, respond to danger by releasing adrenaline and related hormones called catecholamines. Heart rate climbs, blood pressure spikes, the skin flushes or goes pale, breathing quickens. That cascade is normal and protective. In a person with a pheochromocytoma, a rare tumor of the adrenal gland's inner layer, that same cascade fires without any danger present at all. The tumor is composed of chromaffin cells, the same cells that ordinarily manufacture and store catecholamines. When those cells form a tumor, they can synthesize and release those hormones in unpredictable surges, flooding the bloodstream with a chemical signal that the brain reads as mortal emergency. The person experiencing the surge feels exactly what the chemistry is telling them to feel. Terror, pounding pulse, drenching sweat, a vice around the skull. Nothing in that moment suggests a growth sitting quietly on an adrenal gland. Everything suggests a mind in crisis. The episodes that first brought this case to clinical attention fit the anxiety pattern closely enough that initial management followed anxiety protocols. There was no single dramatic event, no collapse, no obvious physical sign pointing elsewhere. What there was over time was a pattern that did not quite behave the way anxiety typically does. The attacks arrived in distinct waves, rather than building gradually with identifiable psychological triggers. They sometimes woke the patient from sleep, a feature less characteristic of panic disorder. Blood pressure readings, taken during or immediately after a spell, were unusually elevated, reaching levels that clinicians documented as difficult to explain by stress response alone. Headache, racing heart, and excessive sweating form what the medical literature identifies as the classic triad of pheochromocytoma. Individually, each is common. Together, arriving in paroxysms, paroxysm meaning sudden bursts that resolve on their own, they begin to point somewhere more specific. The tumor was also producing a symptom that looked almost indistinguishable from the psychiatric manifestations sometimes listed in the clinical literature on this condition: anxiety, panic attacks, nervousness, tremors. Pheochromocytoma has earned the label the Great Mimic precisely because its secreted hormones can reproduce the experience of almost any high-stress, cardiac, or psychological event. What redirected the diagnostic path was a blood pressure reading taken during an episode rather than between them. Systolic pressure, the upper number in a blood pressure measurement, had reached a level above 200 millimeters of mercury. That number sits in the range the literature defines as hypertensive emergency, a crisis where pressure is high enough to threaten the heart, brain, and kidneys directly. Anxiety can raise blood pressure, but readings of that magnitude demanded a different explanation. With hypertensive crisis now documented, the differential diagnosis, meaning the ranked list of possible conditions being actively investigated, expanded. Essential hypertension, meaning high blood pressure without a single identifiable cause, was considered. So was a thyroid disorder, cardiac arrhythmia, and hypoglycemia. Each could produce some of what was being observed. None produced the specific combination as cleanly as an episodic catecholamine-secreting tumor. Laboratory testing for catecholamine metabolites in urine and blood became the next step. The body breaks catecholamines down into measurable byproducts called metanephrines. Elevated metanephrines in a 24-hour urine collection or in plasma represent the primary biochemical evidence for pheochromocytoma. That measurement had not been obtained during the anxiety-focused phase of the case. Imaging confirmed a mass on the adrenal gland. The location was consistent with the published anatomy of pheochromocytoma, which arises most commonly in the adrenal medulla, the inner layer of the gland, and more rarely in extra-adrenal chromaffin tissue elsewhere in the abdomen. The size and imaging characteristics supported the diagnosis. Together, the biochemistry and the imaging closed the diagnostic argument. Understanding the mechanism explains why the misdiagnosis carried real danger, not just inconvenience. Beta blockers, a class of medication commonly prescribed for high blood pressure and anxiety-related cardiac symptoms, are documented in the literature as potentially harmful in undiagnosed pheochromocytoma. The reason is a physiological imbalance. Blocking only the beta-adrenergic receptors while the tumor continues flooding the body with catecholamines leaves the alpha-adrenergic receptors unopposed, which can paradoxically worsen the hypertensive crisis rather than relieve it. Surgical removal of the tumor is the established treatment. Pre-operative preparation involves careful pharmacological management to stabilize blood pressure before any procedure, because intraoperative manipulation of the tumor can itself trigger a surge. The literature notes that mortality historically associated with pheochromocytoma came largely from surgery and hypertensive crisis, and that outcomes have improved substantially with proper preparation. What this case illustrates is not that anxiety is a dangerous diagnosis to receive. Anxiety is real, common, and deserves treatment. What it illustrates is that episodic symptoms, especially when accompanied by blood pressure readings outside the expected range, benefit from a complete differential. The classic triad of headache, rapid heart rate, and excessive sweating arriving in distinct attacks represents a documented pattern worth investigating biochemically. That investigation requires measuring catecholamine metabolites, a test not routinely ordered in a standard anxiety workup. Pheochromocytoma is rare. The literature estimates it in roughly 1 in 1,000 patients presenting with high blood pressure, which means most people with episodic hypertension will not have this diagnosis. A single case cannot establish what is typical or predict another person's outcome. What documented cases collectively establish is that the tumor can mimic anxiety convincingly enough to delay diagnosis for months, and that the delay has measurable consequences for cardiovascular safety. After correct diagnosis and surgical management, the episodic surges that had defined the preceding months no longer had a source. The biochemistry that had been manufacturing a chronic false emergency was removed. The body's stress response, which had been commandeered by a growth the size of a small plum, returned to responding only when asked. That is the thing about pheochromocytoma that makes it stay with clinicians who encounter it. The patient was not imagining the terror. The pounding heart was real. The crushing headache was real. The sweat, the tremor, the sense of impending catastrophe, all of it was real, generated by measurable chemistry, documented in lab values and blood pressure numbers. The tumor was producing a physiological experience that felt indistinguishable from a mind in free fall. And the distance between those two explanations, one requiring a biochemical test and an imaging study, the other requiring only reassurance, determined whether the real cause was found. This video is based on a publicly documented medical case and is intended for education and storytelling only. It is not medical advice. If you are experiencing concerning symptoms, consult a licensed medical professional. The question Pheochromocytoma quietly asks every clinician who encounters it is whether a pattern that fits a common explanation might also fit a rarer one, and whether the cost of checking is worth bearing before the cost of not checking becomes clear. In this case, it was. Medical mysteries. Every symptom has a story. Every patient deserves to be heard. Medical disclaimer. This video is based on real, publicly documented medical case reports and is intended for educational and storytelling purposes only. It is not medical advice. If you or someone you know is experiencing similar symptoms, please consult a licensed physician immediately.